Okay. What's up, everyone? This will be the Dermpath curriculum. And so the couple of ground rules. So first of all, this is completely optional. If you guys feel like you're getting something out of it, feel free to stay. If you're not, you can leave at any time. We'll generally go around an hour, maybe hour and a half, depending. We'll probably cover between 1 and 1.5 or 2 chapters. This will be based off the Elston curriculum. Couple of quick things and little things I see people getting started into Dermpath and making a little sort of mistakes or things that help them early on but hurt them in the long run. First thing, how many of you guys do this? You take a look at a specimen and then you're like, I need it to be, I'm OCD, so I need it to be like this. Pinwheel it. Anyone do that?
I try not to.
Yeah, well, if you do, don't. That'll help you in the short run. It's going to hurt you in the long run. Why? Why am I saying that? Here's an example of how this is going to happen on your core. Number one, you're not going to be able to do that on your core. There is no pinwheel button. So here's an example of what you'll see. Here's an example of what you'll see. You'll notice it's a little bit not straight. It's slanted. So you'll be like, oh my gosh, I've been pinwheeling slides my whole life. Like, what am I going to do here? I got to make it like straight. Okay, well, where's the button? Like, where's the, hold on. What about R, rotate, right? Let's click on that. Doesn't work. That just resets you to the beginning. So that's how the interface is on your core. There is no pinwheel for the core. You will not be able to rotate anything. If something is happening horizontal, you'll sign it out horizontal. If something's upside down, you'll have to interpret it upside down. That's just the way it is. Same thing with a coda. By the way, just in the interest, let's do this since we already have it up on the table. So what kind of pattern are we seeing?
Is it like an interface dermatitis?
Good. Okay. What kind of interface dermatitis? How would you classify it?
Vacuolar.
Good. Vacuolar interface dermatitis. What else is there?
There's
Dead
some
rods.
vascular infiltrate
Superficial, perivascular, and what else?
and deep perivascular.
Yeah, superficial, deep, periadnexal. Exactly. So what are we thinking?
Hernia?
So pernio, you'd like, so a couple things for pernio. So you can have pernio on not on a location like this. Where do you classically see pernio?
Acral sites, and this doesn't have like a thickened stratum granulosum.
Yeah, so the first clue about pernio, yeah, you usually see it in volar skin. And this is, whatever this is, it's not volar skin. And you usually see it around what structure specifically. So this is superficial deep periadnexal. Which adnexal structure? So we see it around the hair follicles. We also see it around eccrine glands. Which of the two do we typically associate that with pernio?
I think it's like puffy vascular changes.
But which of the adnexal structures is the
Eccrine?
Eccrine, yes, eccrine. Typically, there's a bunch of eccrine glands. You see the deep inflammation. Sometimes you can even track the eccrine gland all the way up with the inflammation. But in this case, there's more going on. There's also inflammation around other adnexal structures. But just be more broad. Instead of pernia, what has superficial and deep lymphocytic inflammation and adnexal with the
lupus?
Yeah, collagen vascular disease, like lupus in this case. Lupus, your go-to when you see superficial and deep perivascular and periadnexal inflammation, you have to think about connective tissue disease. You have to think about, okay, is this some sort of lupus, dermatomyositis? You have to rule that out. That should be the first thing that comes to your mind.
Hmm.
And then
Yeah,
if you
no.
see this interface dermatitis, does that go along with lupus?
Yes.
Yeah. What type of lupus does that go along with specifically?
Discoid lupus?
Discoid. Yeah, good. Discoid lupus. Why not acute?
Sorry,
Why
what
not?
specifically is, or what did you just say that's specific to discoid versus other types of lupus?
So the extent of this interface dermatitis is better for discoid lupus. Why am I saying that? So let's say we take, acute SLE, you see someone who has a butterfly rash. What happens when that butterfly rash goes away? Do they get scarred up?
No.
No, it just goes away. That's not a coincidence. There's a reason why they're not scarring. They're not scarring because they don't have this extent of interface dermatitis. This is what causes the scar in DLE. It's just this, all of this death, this necrotic keratinocytes. When you see it to that degree, that's good for DLE. And DLE, what happens when DLE goes away?
Scarring and atrophy.
Scar. Yeah, exactly. It scars. This is good for DLE. Now, for the purposes of your boards, what I just told you is what happens in real life. For the purposes of your boards, don't say it's not SLE because you see extensive interface dermatitis, even though in real life it is, because some people who write the boards still put questions on where there is an interface dermatitis, and the correct answer is SLE.
Right, like they're not going to give us DLE and SLE for this unless there's some like clinical correlation.
Or there's something more obvious features. So for example, if there's follicular plugging
Right.
with this, then okay, that's a slam dunk for DLE. Good. All right. Okay. Now what's going on over here? Oh, I've already pre-pinwheeled this. Hold on. We got to make it slanted. There we go.
It looks acanthotic and hyperkeratotic.
Okay. So acanthosis, yes, it's a type of, there is acanthosis and it is hyperkeratotic.
Choreiaciform reaction pattern.
You can give me a reaction pattern, you can give me a tumor pattern.
I also see a little bit like spongiotic, like epidermal changes. I'm not quite sure from a low power.
Yeah, there are spongiotic changes here. I agree. But I think it's actually easier if we go low power. Like, what's this architecture look like?
Looks like a sub.
Looks like
Yeah,
a
looks like
seb. Yes,
wafer
good.
thin, like clear cell acantoma, maybe.
Looks like a seb. Now, you're saying clear cell acantoma because you see areas where it's more clear. Now, okay. In that case,
But for clear cell, you need the border, right, to look different.
so that's okay. So clear cell, you want to see the borders. Let me, for those who said clear cell, I want you to tell me what this is.
Clear cell.
That's a clear cell acantoma.
Yeah, that has a border there.
Okay. Now, let's say they didn't have a border. So let's just say I'm giving you this without the border. Besides the clear cell, what are features of clear cell acantoma?
Like the cells are very pale, monotonous. Like was it amphiphilic?
The cells are pale. What is the pattern here? Like, look at, what's this? What's this pattern? Psoriasiform. Yeah. Clear cell acanthomas have a psoriasiform pattern. And by the way, when I go in high power, what are these cells?
Neutrophil.
Neutrophils, yes. So this can have a lot of features of psoriasis, not just the psoriasiform pattern. Clear cell acanthomas can mimic psoriasis in many ways histologically. But that is the difference, the clear cell and the border. Now let's go back to this and tell me what's different.
Those are more eosinophilic, not so much like clear. The monotonous, and we said it looked like a seb, so I would go with like clonal seb.
Okay, good. Good. Clonal seb. Yeah. So you're noticing that there's two populations. This population, which is the clonal population, and the rest. Perfect. So, and some suggest that when sebs get irritated, you can get these clonal portions of the seb that can start whirling and start looking different. Sometimes you can find squamous eddies. But yes, this is a clonal seb. So you recognize the architecture. Again, this is very good for seb. This structure right here that looks like the rook that you use in chess, for those who play chess. This one looks even better. It has that type of rook-like papillated pattern. In this case, you don't have the squamous eddies. I'm sorry, in this case, you don't have the pseudohorn cyst to give it away. And it can be a little tricky because they're clonal features. But yes, recognizing that there's two different portions is the key to that diagnosis. Now, something that can look similar is this. In fact, this even has that rook-like papillation. So what's going on here? Now, there's a word that you use that I don't really agree with when you describe the previous one. The word was monotonous. And there are somewhat monotonous, but which one looks more monotonous? Look at these cells.
Yeah, I guess I would say what's like bland versus monotonous.
Yeah, which one looks more monotonous?
This one.
This one. This is perfectly monotonous. Like every cell is just, it's almost like a replica. It's not even just a clone. It's like a perfect clone of the rest. And there you can see this little lining of what looks like the border to it. Almost like it's a seb, but it has this like clonal proliferation, but it's not a clonal seb. It's too perfectly monotonous for it. And sometimes it can be hard, but I don't want you to hunt for this structure. I would like you to go off the monotony, but what's this structure?
Is that like a duct?
The duct. Yeah.
Are we dealing with like a peroma?
Well, is it a paroma?
The hydroacanthoma
Hydroacanthoma what?
simplex.
Yeah, hydroacanthoma simplex. Good. Why is it a hydroacanthoma simplex?
Because it's only under epidermis.
Because it's only confined to the epidermis. What if it was epidermis and dermis?
I believe it's paroma.
Paroma, okay. What if it was dermal only?
Dermal duct tumor.
What if it was dermal only with solid and cystic components and hyalinized stroma?
Bioadenoma?
Syringal.
Hydradenoма.
Yeah, hydroadenoma, yes.
Were you thinking of syringofibroadenoma of Moscow Road?
Yeah.
That's a bit different. We'll get to that in time. All right. So those, yeah, be able to differentiate those three. And this?
Oh, can you zoom in on the top section, kind of like towards the right, like 3/4 towards the right?
This section?
Yeah.
Oro?
Yeah. There's one. There's 2. There's 3.
Avi, can you zoom in and like show
Mhm.
me what about this? What is this? What is this structure?
Sure. So, well, let's describe it. And anyone can describe it. So what exactly are we seeing here?
Keratinocytes with nuclei in the stratum corneum.
Okay, there's nuclei in the stratum corneum. What do we call that when there's nuclei in the stratum?
Parakeratosis.
Called parakeratosis. What's different about this? Is it this parakeratosis?
It's columnar kind of like it's yeah.
Yeah, there's this nice column of parakeratosis, often described as at an angle. You can see that better over here. And then when the parakeratosis meets the epi,
That's annoying.
what do you see when the parakeratosis meets the epi?
No granular layer.
Well, there is a granular layer over here. But let's track it down. Look at the parakeratosis. It's hitting the epi, and what cells are these?
Necrotic keratinocytes.
Yeah, just keratotic keratinocytes.
Just keratonic, yeah.
And that's not a coincidence. That's why you have the coronoid lamella in the first place. It's these, and they all have it. You know, let's go. We saw 3 of them, right? Does this have dyskeratotic keratinocytes?
Yes.
Yes. What about our second one?
Yes.
Yeah.
And our third one?
3 for 3. Yeah.
3 for 3. Yeah, so it's not a coincidence. This is what creates the coronoid lamella. It's precisely that dyskeratosis that's creating that column of parakeratosis. So the key here is not to tunnel vision, because look at everything that you can find in the coronoid lamella. Sometimes these can be lichenoid. You can get all sorts of patterns. In this case, where do you think the porokeratosis is?
On the leg.
On the legs. Why?
Oh, there's stasis changes.
Yeah, because look at all of these vessels, this cannonball angioplasia. Okay, good. Well, this one you probably won't be tested on. Okay, let's do this one.
This is a shave biopsy. It looks like as though there's a lot of solar elastosis in the dermpath. I would probably presume that this is going to be some type of malignancy just because based off of that finding.
Yeah, okay, good. So shave biopsy, you notice you're picking up on there's a lot of solar elastosis over here. Good. You're worried about some sort of malignancy. Okay. Are you more worried?
Yes. More worried.
Yes. Okay.
Like
So what
Okay.
kind of malignancy might we be worried about?
squame.
Okay, good. Squam. And why is it a squam and not an AK?
We're seeing some like full thickness atypia, mantoses, and these superbasal layers.
Good. Yeah. Full thickness atypia. Opposed to something like this. First of all, what did the clinician see when they saw this?
Something
Like a wart or just like a lot of hyperkeratosis.
Yeah, and it's really thick, right?
Is that the smokestack sign or something?
Not quite. We'll get
No.
to smokestacks time, but just appreciate how thick this horn is. What happens when you have a horn that just keeps getting thicker and thicker and thicker?
cutaneous horn.
Cutaneous horn. Yeah, the clinician probably saw a cutaneous horn here. So what is our differential for your cutaneous horn before we even look at this? What are the 4 common things at the bottom of a cutaneous horn?
Squamous cell carcinoma.
Oh, so AK.
Yeah, AK squame. 2 more. So AK squame, warts, and septs. Those 4 things could be at the bottom of a cutaneous horn. And clinically, there's no real way to know for sure which is which. So if you see a cutaneous horn, what do you have to do?
Biopsy.
You got to biopsy it. Your hand is forced. Cutaneous horns get biopsied. In this case, let's figure out what it is.
Again, there's like a lot of ciliary elastosis here.
Yeah, definitely sun-exposed patients. Let's look at the horn. What are we seeing? Ortho or para? Or both?
Para.
Okay,
Mostly.
parakeratosis. And what about these areas?
It spares the annexal structures.
Okay, they're sparing. Sparing which structures are being spared? You mentioned adnexal, so which one do you think?
Eccrine doc?
Yeah, acrosyringium, and areas of hair follicle, acrosyringium, acrotrichium. So they're sparing those areas. So that's good for what? That's an indicator that this might be the horn of what?
It makes you think less likely like malignancy because those are being spared. Would it be worse?
It's the type of pattern horn you see in an actinic keratosis.
Hypertrophic AK.
In a hypertrophic AK, and also just AKs as well. They have this sparing pattern. So you see this parakeratosis, but when you get to the areas of acrosyringium and acrotrichium, you see that, oh, it just went away and then it came back and then it went away. And if we follow this through, you can see, okay, well, put a little divider line here. Are these cells typical or atypical?
Like a basal, like an ATPR at the basal layer.
Okay, good. Atypical. And what about these cells? Are they typical or atypical?
Also atypical. They look rather
Also.
pale.
So typical or atypical or typical?
Atypical.
Atypical. So do you see how these cells are smaller than these cells? Like let's talk about what makes cells atypical. So let's go to like normal skin. So these are all normal, these are typical cells. When we get to here, we start to see that this basal layer, what's different about these cells?
They're like hypochromatic. They're more spaced out. They look pale.
Tell me about the size. Are they bigger or smaller?
Bigger.
I'm sorry, come again?
Bigger.
They're bigger, okay. And look at the nuclei. Are the nuclei bigger or smaller?
I guess bigger, hyperchromatic.
Hyperchromatic, bigger. Okay, and then what about these areas? Compared to this area, is this area of the nuclei bigger or smaller?
Smaller.
They're smaller. And compared to this area, are the nuclei in this area hyper or hypochromatic?
Hypochromatic.
Hypochromatic relative to that. These are the signs of maturation. So it's mature. And in fact, you can even see it's starting to form a granular layer over here. So these are more typical cells toward the top. So is this full thickness or not full thickness atypia?
No.
Not full thickness.
Not full thickness atypia. So what diagnosis does that go with?
AK again.
AK versus.
Goes with AK. So everything's going for AK here. The sparing of the parakeratosis of the horn. The non-full thickness atypia. So this is a cutaneous horn caused by a hypertrophic AK. What kind of architecture does this have?
Epilomatous.
Yeah, it's pretty papillated, right? And in fact, tell me about the keratinohyaline granules.
They're pretty dense.
Pretty dense. That makes you think of what?
Wart.
Okay.
That you would call the coilocytic change, right?
Well, coilocytic change has those vacuoles. And in fact, there's some hint of that over here, actually. You're thinking wart. Now the question is it wart or more?
It's more.
Members of Atypia, like large cells in them.
Yeah, what is going on here? What do you see?
Is that like a Maltese cross?
Animal Maltese cross. This is a mitotic figure. It's just pretty large. In fact, there's all sorts of atypia and mitoses all over the place. Some have described the atypia as, or the mitotic figures as windblown, having a windblown appearance.
This looks
That's
like
more SCC, like wart, SCC associated with wart.
Yeah, so HPV-driven SCC, and some people call that a
verrucous carcinoma.
not verruca. Well, let me ask you, since you mentioned that, I'm very glad that you mentioned verrucous carcinoma. So in verrucous carcinoma, you actually don't really see a whole lot of atypia.
Oh, it's that classically characterized by the like pushing border. Oh, it's not like that, I think. Yeah.
Yeah, it's a pushing border, not a whole lot of atypia. It's pretty large. It has inflammatory edematous at the junction between the pushing border. But there's the key is verrucous carcinoma. You typically don't actually see this atypia like that.
This is a bonoid papulosis.
Yeah. This is bonoid papulosis. So it has this architecture of a wart or a condyloma, and when you look at it, it's like, wait a minute, this can't just be a wart or condyloma. This has all this atypia, this scattered atypia throughout. There's mitotic figures. There's no way this could just be a wart. Okay, good. Janky slide, but believe it or not, you will get janky slides on your exam. Just like sometimes you can get old Kodachromes on a clinical exam, you can get an old washed out slide on a Dermpath exam. So how do we tackle it? What's going on with the horn?
So we got some parakeratosis, a little bit of hyperkeratosis.
Okay. Throughout or sparing?
Sparing.
Sparing, okay. And again, look at our divider.
So we're seeing like a bit of atypia and then kind of like normal superficial cells, kind of similar to the AK that we were seeing.
Yeah. Again, these cells down here are atypical. These cells up here are not atypical. Not full thickness. Horn goes for the AK. Atypia goes for the AK. By the way, what sign is this called? I don't know if anyone see. What are we doing? We're patriotic. What do we wave?
So
It's like
flag.
blowing.
Flag sign.
A flag sign, yeah. May have heard that described as the flag sign. Okay, so diagnosis?
AK.
Okay. Okay.
This has some like hyperkeratosis as well. Looks like it reminds me of like wart as well. There's like a clear separation between like where it starts and stops.
Okay, hyperkeratosis. What else are we seeing here?
There's some like acantholysis and dyskeratosis.
Okay, acantholytic dyskeratosis. What kind of structures do we see in acantholytic dyskeratosis?
Corporons and corporanes.
Corpse ronds and grains. Okay, like there, here. Okay, and what's the overall architecture of this?
Looks like a crater.
Yeah, like cup-shaped. This is the way some describe it.
Warty dyskeratoma.
Yeah, warty dyskeratoma. Good. In some cases are cup shaped. Some cases are more of a extensive goblet shape. But same features. You see acantholytic dyskeratosis, you see corons and grains, and if you track it up, you'll see your warty features, your coarse keratinohyalin granules. Okay. What are we dealing with here? What kind of thing are we dealing with here?
Cysts.
Assist, yeah.
Some kind of cyst. Yes. All right. What do we look for? What are the things we look for when we're trying to figure out what kind of cyst we're dealing with?
You want to look if there's like a granular layer, if like they had nexal structures has in between. If
Okay.
there's any like follicles that might be associated, like lymphoid centers or germinal centers.
Okay. We're going to look at the contents. We're going to look at the lining. And we're going to look at the wall. What's in the contents?
Keratin.
Keratin. Good. We should easily be able to answer the question if there's a granular layer.
Yes.
Yes. Okay. Is this a normal granular layer, though?
No.
What's abnormal about it?
There's some vacuolar changes to cells.
There's vacuolar changes. Okay. And what about the granules themselves?
They look
Hyper.
Yeah, they are
Hypergranulosis.
there's hypergranulosis with very dense keratinohyalin granules. And they're more pronounced where? Are they more pronounced at the papilla over here, or are they more pronounced in the dells?
No.
Hypergranulosis in the dells. Warty changes. So what kind of cyst is this?
Verrucous cyst.
Verrucous cyst. Good. Contents?
Keratin.
Keratin. Okay. Lining
With a granular layer.
has a granular layer. What happened to this?
the split from the from the sectioning.
It ruptured.
Okay.
And then you have a what in response?
A little
Lymphocytes.
granulomas.
The foreign body granulomatous, yeah, a granulomatous reaction. So what happened? What is it?
Yes.
ESC.
Yeah,
Yeah, it's a-
ruptured EIC with foreign body reaction, or suppurative and granulomatous dermatitis, or granulomatous foreign body reaction to a ruptured EIC. Good. Contents?
Homogeneous keratin.
Lining?
No granular layer.
What is it?
Highlights.
Tyler cyst.
Mhm.
Like a lemon cyst.
Good. Not much contents. What's the lining here?
Pseudostratified ciliated.
Okay, pseudostratified ciliated over here in this part of the cyst. What's the lining in this part of the cyst?
Smooth muscle.
I'm sorry?
Capitation.
So this can be variable. So in fact, in the same specimen, you see some variation. This is pseudostratified columnar epithelium with cilia. In some areas, you don't see the cilia, and it's not really that complex of a lining. This cyst can vary depending, it mostly varies, the lining varies depending on where it is, but whether its location, but sometimes you can see variation in the same lining. So variable cilia for the lining. And what's this structure?
The thyroid. I don't know. Thyroid.
Follicles.
Yes.
Yeah, globule.
Thyroid follicles. So these eosinophilic to pink, homogeneous, almost frothy type looking material. You don't always see that. You can see them like 30 to 60% of these cysts. If you step section through it, you can increase your yield of seeing those thyroid follicles. But that's the giveaway. And these can get very inflammatory. Sometimes the inflammation itself can denude portions of the cyst lining itself, like you're seeing over here. So what is this?
Thyroglossal cyst.
Thyroglossal duct cysts. And what do we do with thyroglossal duct cysts?
We image them to see if they connect.
Yeah, we can. I mean, you can image them. I think that's more for certain other types of cysts. But what ultimately? I'm talking about treatment. Ultimately, what's the recommended treatment? So it's surgical removal. The ultimate destination for thyroglossal duct cysts, unless there's some contraindication, is a surgical removal. Does anyone know why?
Can't they have like recurrent infections if they're not removed?
Yeah, exactly. They get infected. It's not malignant transformation. Malignant transformation is very rare in thyroglossal duct cysts. It's less than 1%, and when it happens, it's usually a papillary thyroid. But it's usually just they get infected over and over and over again, so they have to be removed. This is more of the same. And now
could you?
Important. Yeah, go ahead.
I was wondering if you could just quickly compare the thyroglossal cyst to a brachial cleft cyst, because I feel like I keep on getting those lymphoid follicles confused.
That's a great question. What do you think this cyst is?
Germinal center.
Oh, okay. I see so yeah, like Nick was saying, so those are the germinal centers, and they look way
These are the
less
follicles.
The follicle.
These are the lymphoid follicles that you see in what?
Branchial cleft cyst.
Yeah.
Branchial cleft cyst. Yes. So it's important to look at the inflammation, because this can get very inflammatory, and it's important to notice, like, okay, is this just inflammation, or is this actually starting to form lymphoid follicles? In this case, it's just inflammation. In this case, they are neatly forming lymphoid follicles. And that's a giveaway.
And the brachial cleft cyst also has the pseudostratified lining.
It also can have a very, like, let's take a look. So tell me what lining this has. Is it pseudostratified columnar?
It doesn't look like it.
Like regular squamous.
Yeah. Stratified squamous epithelium. Here's another example. Stratified. Now it's starting to be. Now it's starting to look. What are we getting here?
This looks more pseudostratified.
Yeah, now it's starting to look more pseudostratified columnar. So again, you can't look at don't reflexively see, oh, this looks like pseudostratified columnar epithelium, so it's got to be this. It's not going to work. And speaking of that type, this one has the clearest type of that, which is this lining.
Yeah, respiratory epithelial.
Okay, and respiratory epithelial is?
If you zoom out, we can see some, maybe on the edge there, some smooth muscle on the left edge.
Let's talk about the lining first. We'll get there. It's pseudostratified columnar epithelium with.
Not great. We'll note like spontaneous but goblet cells.
Yeah, with cilia, and then if you look, you'll be able to find some goblet cells. And then you mentioned the. Go ahead.
Sorry. Can you point out a goblet cell again?
Yeah, let me find some good ones. Well, there's not much here. Here we're starting to get some. There might be a few good ones over here. If I can get the quintessential goblet cell. But do you see how some of these cells have look like they're packed with certain mucinous material?
Mm-hmm.
That's what goblet cells. The goblet cells are in the respiratory epithelium. They're not the prettiest examples here, and here we don't really, as opposed to this, where we barely see any of them. In this side, like we have like, they're not the best, but if you look at like this, see how that's lighter?
Yeah.
Okay, and then in the wall, what do we see?
Smooth muscle. Smooth.
Okay, smooth muscle. So what do we all think this is?
Morphogenic stuff.
Bronchogenic cyst, yeah, it's recapitulating everything. You have a bronchospasm because that's the smooth muscle that contracts when you have a bronchospasm. Bronchogenic cysts are just that. They're recapitulating the same thing. It's just all of the features there are present in here.
Avi, for the core, will it give you like a little bit of a history? I know like sometimes it can just give you the actual pathology slide and that's it, but like will it say like, oh, this cyst is more midline or it moves or swallowing or anything?
The answer is sometimes yes, sometimes no. So for differentiating these types of cysts, look, in the core exams, it's the way I like to phrase it, it's you get the 80-20, it's like the 80-10-10 rule. 80% of your exam is fair. 10% of your exam is going to be a giveaway. So if they give you these cysts to differentiate and they give you clinical, I consider that 10% of the giveaway questions, because then it's just too easy. You are expected to differentiate these on path alone, and that is the 80%. That's fair. If they give you clinical, it's easy, 10%. And then the other 10% is going to be what sets the curve. The other 10% is just going to be, okay, well, we need people to get some questions wrong. So if they want to give you some freebies, they can give you clinical for this. I would consider it fair to expect you to differentiate these on path alone. More of the same. What about this?
Steatocystoma.
Yeah,
The
this is the
autostoma. You
basic
got that
one.
shark tooth lining, and then you have your associated sebaceous gland. Fairly straightforward. Okay.
More of the same.
More of the same. Good. Now notice you didn't say, oh, there's no shark tooth lining. It can't be a steatocystoma. You notice that, okay, well, steatocystomas have the associated sebaceous glands without the rest of the follicle. So that's a steatocystoma as well. Good job.
Wait, sorry, can you point out the sebaceous
Sure.
gland? Mhm. I
See it?
did think that this one didn't have the shark tooth lining, so I was like, okay, it can't be a steatocystoma.
Yeah.
But
You don't have to have a perfect shark tooth lining for steatocystoma. It's a cyst that has these associated sebaceous glands. They do not, though, have the rest of the follicle associated with them. Like this, which has what?
Hair other annexal structure like hair.
Yeah, it has the rest of the hair follicle associated with it. And in the cyst, you have what in terms of contents?
Keratin as well.
You have hair. And what kind of hair is being dumped into the cyst? Is it vellus hair or is it non-vellus hair?
Vellus hair.
You're saying it's vellus hair?
Yeah, because I thought it was smaller.
Vellus hairs would be smaller than this. Like this is, let's just do a little comparison. This is quite a large cyst. Vellus hair, eruptive vellus hair cysts, they're usually smaller and they have the hair shafts are not typically this big. And you'll notice that there's the association is sebaceous gland and the rest of these like follicles. Now they're miniaturized to some degree, but they're not vellus.
So this is like dermoid cyst.
Yeah, in some cases, like dermoid cysts can kind of fake you out. Like you might look at this and be like, "Oh, this is shark tooth lining." It's not quite, but it's not quite the shark tooth lining. But the key here is to see not just sebaceous glands, but like the rest of the follicle going in, and you can see these full hair shafts in there as well. And it's quite large. Like this is a big. It's not like that teeny tiny little. And sometimes look at all this. Look at all of these hair shafts. Like this is too much for just Ellis. And this one. So lining.
Ciliated.
Yes, it is.
Yeah,
Dermpath.
ciliated. And like in some areas, you'll notice, what does it just look like?
Do they look cuboidal? No.
Yeah, and look, what kind of secretion does it look like it has?
It almost looks like decapitation.
Yeah, it kind of looks like decapitation secretion. And you might, so the trick is not to just call this a what? If you just see something like this with decapitation secretion, what are you going to call it?
Like a cyst of the apocrine gland or something.
Yeah, like. What's the most simple cyst of the apocrine gland? That
Okay.
just has a lining and decapitation secretion, and that's it. See them on the eye, around the eyelids.
Syringoma.
Syringoma is simple.
Hydrocystoma?
Hydrocystoma. Yeah, hydrocystoma is your simplest apocrine cyst. It has your decapitation secretion lining. So the trick is to not call this a hydrocystoma. And the way to do that is to confirm. So whenever you're going to call something, if you're going to call something a hydrocystoma, just don't forget just do a quick check, make sure you're not dealing with this, which has cilia, and in some areas looks like it has decapitation secretion like a hydrocystoma. So what is this? Anyone know?
So like cutaneous cilia cyst.
Yes, good. Cutaneous ciliated cyst. That's right.
Well, would you expect to see a lot of debris like in that cutaneous ciliated cyst?
Well, you tell me. This is a cutaneous ciliated cyst. Do you see a lot of debris here?
No.
No. Don't make the call by how much debris there is. Just make the call by what the essential features are. All right. Okay, what kind of biopsy is this?
This shit, whatever you said that before. I remember like a 16mm punch.
Yeah, 16mm punch. No, well, it's
Like
all right. So an excision, right? We excise something. Any features where we might be?
Are we dealing with like the nipple areola?
Yeah. Okay. Good. So what clued you into that?
Well, I don't see any like hair follicles or anything like that. And then there's like those glands and ducts that look like
You don't see any hair follicles.
Is that it? Okay. Never mind.
What's this?
A hair follicle.
Can you get hair follicles?
Yeah. I mean, I
Yeah.
got both
Yeah, you
there.
can. Not the most convenient if you have it there for some people, but you can. This one does. All right. So yes, you can. So that you can have that feature there. But what else did he mention?
Smooth muscle.
Yeah, exactly. Smooth, a lot of smooth muscle tells you, okay, so you're on erectile tissue, anogenital or nipple by areola. Anything else that might give it away?
Are those like the mammary glands?
Yeah, these are ducts. We haven't gotten, I don't know if we got deep enough to the mammary glands just yet, but we definitely have ductal tissue. Yeah. So what's going on over here?
Buckshot scatter.
Okay.
Scatter.
Pagetoid cells and pagetoid pattern.
Paget's disease.
Paget's disease. Okay. So how would you stain this?
Is it
CK7 and CK20, or CK7 for above, yeah,
CK7 will be positive. What about CK20?
would be negative, or I guess
Negative
it's like
is negative except for when?
below the diaphragm.
Specifically, there's a specific extra mammary Paget's disease located in one area that will stain positive for CK20. Sometimes. What area is that?
I don't know, anogenital.
Yeah, well, anal. Perianal extramammary Paget's disease will variably stain positive for CK20. Otherwise, it will not. Okay. So yes, it will stain positive for CK7. You're going to do your ER, PR, HER2. What about what's going on down here?
Periductal infiltrate and inflammation.
Yeah, let's do a little comparison. Okay. Now, I personally do not have these structures. I'll check again. I don't have them. But if I did have them, which one would I rather have?
the one on top?
The one on top. Yes, the one that's not obviously cancer. This is ductal carcinoma. So when we see mammary Paget's disease, this is why it's a big deal. Because there's a strong association between mammary Paget's disease and what lies below. What lies beneath is a cancer. This is why mammary Paget's disease can end up resulting in mastectomies. What about this?
Also seeing pagetoid spread.
Pagetoid cells and pagetoid pattern. Now notice there's they have this off-white mucin tinged color to them. And do you see, let me ask you, is there a tendency for them to be at all levels, or do you get areas where you have these cells that are trying to be above the basal layer?
Yeah, it almost looks like they're all they're like nested.
What kind of nesting? Is the nesting at the tips of the reedy, or is it above? There are areas where it's trying to be above the basal layer. So like this is the kind of thing I'm talking about.
It looks like it's above the face.
Yeah, like these are all
I see
your
it like throughout.
look, see that cutoff? It's not the only area that has it. Now it's not 100%. I'll just tell you that. So this doesn't always work all of the time. But you will find areas like that. And see what the other cuts are. Where you'll see a tendency for them to try to spread, you'll see a little residual basal layer. It crushes it a little bit, but it doesn't completely overtake it. And that's a feature of this entity, which is also a feature of the entity we looked at before.
Extra memory packets.
Extra memory packets. Yeah. The only difference in this case is the location. It will stay in the same way. Benign or malignant?
Benign.
Iffy.
Benign. Okay. Why benign? What are the three things we look at low power to assess benignity versus malignancy?
Symmetry.
Okay. I drew a line. Is it symmetric?
Yes.
Yes.
Yeah.
What else?
Circumscription.
Right.
Circumscription. I drew a line. Is it well circumscribed?
Yeah.
Okay. The one thing that's going against it is size, because it's fairly large, but it is symmetric and well circumscribed. And what kind of lesion are we dealing with?
Melanocytic lesion.
Melanocytic. Okay. So how do we? So our question is nevus versus melanoma. So what are we looking for?
For melanoma, you could consider like ulceration, atypia, mitoses.
Those are typically the things we don't look for: atypia or mitoses for melanoma.
Look at the single cells.
Single cells. Okay. Single cells predominate over nest. What else?
Lack of maturation.
Okay. And by maturation, we mean the decrease in size of the melanocytes. There's something else that's more important than that, though.
Whether the melanocytes go above the basal layer.
Yes, pagetoid spread. How much pagetosis there is. Okay, so pagetoid spread, pagetoid cells and pagetoid pattern. Do single cells predominate over nests? Do they trail off in single cells or do they end in a nest? It's another feature some people use. Ending in a nest is benignant, is more characteristic of benignity versus trailing off. And then size, symmetry, circumscription. In this case, do single cells predominate over nests?
No.
No.
Is there pagetoid cells and pagetoid pattern?
Yes.
Yes. Is it mostly in the center?
Most in the center.
Okay. And describe the nesting.
Wait, why does it matter if it's more in the center?
Because there's an entity that is typically you get more pagetoid cells and pagetoid pattern in the center rather than the outside, rather than the lateral areas of the lesion. Happens to be this entity. What kind of nests are these?
Like large spindle or banana-like
Okay, yeah, banana-like bodies. Okay, you're describing all the features here. What's this then? Tell us what this is.
Camino body.
Camino body. And what is a camino body?
It's a collagen type 4.
Collagen type 4. Good.
PAS, you shoot spits.
This is a Spitz nevus. Yes, very good. And yes, Spitz nevus nevi can have some pagetoid cells and pagetoid pattern. But you'll notice it's pretty extensive over here in the center. But not a whole lot going on in the lateral edges. That's okay.
Avi, could you just briefly zoom in on the Camino body one more time, please?
You got it. Check that out. See all that type 4 collagen?
Got it. Thank you.
Boom.
So it's that the single cells are more in the center? Or the
Yes. So
Okay.
see here, you can see here. These cells that are rising up,
Hmm.
they're at the center, they're more pronounced to the center of lesion. You can even see some remnant cells in the horn. Whereas if we were to go to the lateral margins, not so much. The
Hmm,
horn is free of these pagetoid cells and these remnants of pagetoid cells, not in the center.
got it.
Is this the only exception for benignity for pagetoid cells?
No, it's not. Sometimes you can just see some degree of pagetoid cells, and it's just an it's just a litigious junctional nevus with atypia or something. Some nevi can have some degree of pagetoid cells and pagetoid pattern. Doesn't mean if I found 1 or 2 cells in pagetoid pattern, that means it's a melanoma. Not quite. No. It's degree, pattern and degree.
I see this is like a shade biopsy on a sun exposed area with a lot of those cells on the epidermal layer look not healthy at all. Very large with a hyperchromasia. A lot of tepia. I think actually they're approaching to the top layer of the epidermis.
What kind of cells are they?
I would consider them as keratinocytes or maybe just melanocytes. It's hard to tell.
Well, is it hard to tell?
Those are melanocytes.
Yeah. How do we tell the difference?
It's a pale nucleate, like
Yeah, the color's different, and what's lacking between, like, if I were to just go into these 2 cells of the same type, what's lacking between these 2 cells that the keratinocytes have between each other?
Yeah, the drug pill oh, I forgot the term for that.
The desmosome.
The desmosomes. They don't have desmosomes. Okay, and by the way, in contrast to the extramammary Paget's disease, where there had some areas of tendency for them to be above the basilar layer, what's going on here?
It seems to just be basilar and subbasal.
Yeah, they are in other areas, but they're not respecting the basal layer. That's a key difference. They're not respecting the basal layer, which makes sense because melanocytes originate from the basal layer. I mean, the melanocytes are in the basal layer normally. So in this case, the melanocytes are in the basal layer and they're also spreading up top. And do single cells predominate over nests?
Yes.
Yeah. In fact, are there any nests?
No.
No, it's just a bunch of single cells with pagetoid cells and pagetoid pattern on sun-damaged skin. What's your diagnosis?
Melanoma.
Yeah, this is melanoma in situ. Yeah. Again,
This
as
is
opposed-
sun damaged skin. Lentigo maligna wouldn't.
yeah, if you called this lentigo maligna, see what you want to see for lentigo maligna, and you do see some of that, is like the cells going down a hair follicle. If you called it lentigo maligna is a melanoma in situ, so that would be fine. And again, as opposed to this, look at the areas here. Where you can see some crush of the basilar layer, but it's not completely replacing the basilar layer. I think I'm going to have to reload this. There we go. So that's the same diagnosis. What kind of lesion are we dealing with here?
Like neoplastic.
Okay. What kind of cells are they?
Nested cells. Pigmented.
Yeah, so melanocytic, right?
So this is malignant melanoma.
Yeah, I mean, look, this is very broad. It's going across the entire biopsy, the entire excision. Completely asymmetric, by the way. In this case, you have some areas where it's just junctional. In this case, you have a clearly compound, or in the dermis, I should say. There's pagetoid cells and pagetoid pattern throughout. They're spitting out into the cornified layer. Like they're screaming at you, like, I am pagetoid cells and pagetoid pattern. Good, and they're nesting, okay. Melanoma. More than in situ. And this?
Looks like a lot of keratinocyte atypia,
Yeah,
like a SCCIS.
good. Squam in situ. Notice these actually do have desmosomes, and there's like, okay, excellent. This is a fairly easy one.
BCC.
Yeah. Stroma, by the way, the margin is defined by the stroma, not the tumor. And this is?
Keratocanthoma.
Keratoacanthoma, exoendophytic. Kind of looks like a volcano. Also has, what's this? What cells are in here?
Oh, the squamous eddies.
Well, squamous, well, there's a type of cell in here that's doing more than that. Like these are, like this is a squamous eddy.
Hmm.
But what's going on here? What kind of cells are in here?
Keratinocytes.
And
Neutrophil?
kind of inflammatory cells in here.
Neutrophil.
Neutrophils, yeah. So you can get these little neutrophilic microabscesses in keratoacanthomas. In fact, that's a feature of keratoacanthomas, neutrophilic microabscesses. And this?
Yeah. So initially I was thinking it kind of looked like basal cell, but there's full thickness atypia. There's really no clefting or like parallel like stroma, so like SCC.
Yeah, squame. Okay, is it in situ?
Well,
No.
it's epidermis, so no.
No, it's invasive. Superficially, it's squamous cell carcinoma. Superficially invasive or invasive, it's fine. In this case, you can argue that it's like has features of arising in an actinic keratosis because you can see, okay, well, there's sparing para in some areas, and this area is normal. But like once you get here, it's full thickness atypia. So you can get squamous cell carcinomas that have arisen in actinic keratoses. And if we say that, does the patient get Mohs if it's a squamous cell carcinoma arising in an AK? Last I checked, that does not meet appropriate use criteria for Mohs. And this?
Invasive SCC.
Invasive
Yeah,
SCC, well differentiated.
Another SCC.
Another SCC, not as well differentiated. By differentiation, I'm just referring to the degree of keratinization, by the way. All right. See one, do one, teach one.
So we did like a bunch of SCCs, but I feel like I'm not seeing atypia. I'm seeing like maybe pseudohorn cysts. Which actually looks more like a seb to me.
What kind of sub?
Clonal?
Clonal. Our old friend, clonal sub, made a comeback. Good. What about this?
like an inflamed SK.
It has some architecture of an SK and has a horn that can make it look like an SK, but it has like a kind of sort of like, what does this whole area look like? What's going on here?
Like create terraform.
Like it has like, yeah, it's not, it's sort of Cray Terraform, but it's not like that other KA we saw. It has fibrosis underneath it. What's all this? Clumps of solar elastosis. So what do we think this is?
KA.
KA, yeah. What's different about this KA?
I mean, it looks like more differentiated.
This is a resolving KA. So KAs can resolve. What you see is it's not quite, doesn't have that profound exoendophytic volcano-like Cray Terraform appearance, but it has some semblance of like a cyst-like opening. And underneath, you can see areas of fibrosis. And in some areas, you see these clumps of elastin fibers. And so the idea is when some say that when keratoacanthomas grow, they gobble up, they incorporate elastin fibers, and when they regress, they let it all go. And so you get these clumps of elastin fibers. At least that's an Elstonism. But you could also see the fibrosis over here that was caused by the keratoacanthoma when it was growing. And then one other thing that I like to show is when a keratoacanthoma goes down, what do you say when it says, if I'm going down, I'm taking you with me? Gives you the middle finger. There's a middle finger in there somewhere. They almost all have one. A little papillation in the middle that says, yeah, I'm defeated, I'm going, but look at the scar that you're going to get. All right. Okay, we'll get started on 15 and beyond next session. But good job, guys. All right, have a good one.
Thank you, Avi.
Thank you, Avi.
Thank you.
You got it.